A continuación vamos a empezar la última mesa sobre cirrosis hepática y en particular sobre el tratamiento del hepatocarcinoma. La primera charla corresponde a la doctora María Varela del Hospital Central de Asturias, que nos va a hablar sobre el tratamiento sistémico del cáncer hepático.
Hola, buenas tardes. ¿Me oís bien? ¿Me oís bien? Espero que sí. Muchas gracias al doctor Andrade por invitarme a participar en esta reunión y en primer lugar quería disculparme por no poder estar ahí de forma presencial. Al final de la evolución de los pacientes con enfermedades hepáticas, si sobreviven lo suficiente a las complicaciones o a la comorbilidad, siempre aparece el cáncer. Estos son mis conflictos de interés. Como sabemos, el cáncer hepático está dividido por estadios en función de la presencia de síntomas, de la carga tumoral y de la enfermedad extrahepática, y utilizamos el tratamiento sistémico como primera elección en aquellos pacientes que presentan un tumor en estadio avanzado, definido por la presencia de carga tumoral extrahepática y por la presencia de mínimos síntomas asociados al tumor. Asimismo, el tratamiento sistémico se puede utilizar en pacientes que están en estadio intermedio o en estadio inicial, que han agotado su tratamiento de primera línea y que ya no son candidatos a recibir más tratamientos de termoablación o de tratamiento intraarterial. Nuestro objetivo con el paciente que presenta un cáncer avanzado es que este paciente viva más y viva mejor. Y para ello tenemos que hacer una evaluación global conjunta con el paciente acerca de diversos aspectos. Primero, la carga tumoral. Segundo, analizar muy bien la reserva funcional hepática. Si el paciente tiene una cirrosis descompensada o ha tenido una historia reciente de descompensaciones, hay que tener mucho cuidado a la hora de indicar un tratamiento sistémico. Hay que evaluar el perfil del paciente desde el punto de vista cardiovascular y además tener en cuenta los deseos del paciente y su capacidad para recibir el tratamiento con seguridad. El primer tipo de tratamiento sistémico que tenemos disponible son los inhibidores multiquinasa, que son fármacos que se administran por vía oral. Sorafenib fue el primer fármaco sistémico con aprobación para hepatocarcinoma hace ya casi 13 años. Son fármacos, como digo, que se unen al receptor transmembrana de diversos receptores tirosinquinasa, y después de esta unión se activan diversas vías celulares que conllevan una alteración en la transcripción nuclear que finalmente consigue un efecto antiproliferativo y antiangiogénico. Como son fármacos multiquinasa, afectan también a las células sanas y en mayor o menor espectro tienen efectos tóxicos que afectan a la mucosa gastrointestinal, produciendo diarrea, a la piel, produciendo síndrome mano-pie. Por el efecto antiangiogénico pueden producir más o menos hipertensión y eventos cardiovasculares y síntomas generales como anorexia, cansancio y pérdida de peso. Además, estos fármacos son capaces, por su efecto citotóxico directo, producir una muerte celular inmunogénica. Se libera del retículo endoplásmico al morir las células tumorales calreticulina, ATP y otras proteínas que son capaces de generar una maduración de las células dendríticas que favorece la activación del sistema inmunológico, y por ello se utilizan en el momento actual como terapia de combinación con los fármacos de inmunomoduladores. El segundo tipo de fármacos que utilizamos en el cáncer de hígado en el momento actual son los antiangiogénicos puros, bevacizumab en primera línea y ramucirumab en segunda línea. Son anticuerpos monoclonales dirigidos específicamente contra el vascular endothelial growth factor, y estos fármacos se administran por vía intravenosa. Además, como los inhibidores multiquinasa también inhiben este receptor tirosinquinasa, el mecanismo de acción por el que actúan es similar. la importancia de inhibir este factor, el Vascular Endothelial Growth Factor, es múltiple. Por un lado, como digo, conseguimos la maduración de las células presentadoras de antígeno. Por otro lado, conseguimos normalizar la vascularización del tumor y además conseguimos modular el microambiente tumoral para que éste sea más agresivo con el tumor, sea menos tolerante. Inhiben los macrófagos asociados al tumor, aumenta la proliferación y la infiltración por células natural killer y por linfocitos CD8, y todo ello hace que sean excelentes compañeros de viaje a la hora de tratar el carcinoma hepatocelular. Pero como digo, los efectos adversos de los antiangiogénicos pueden ser notables. Bevacizumab se asocia con un riesgo relevante de isquemia cardíaca, de isquemia cerebral, de hemorragia y de hipertensión arterial. Y sorafenib, al igual que los otros fármacos inhibidores multiquinasa, también se asocia con mayor riesgo de episodios aterotrombóticos y de hemorragia. Por tanto, es muy importante analizar bien cuál es el riesgo cardiovascular y cuáles son los factores cardiovasculares basales de nuestros pacientes a la hora de indicar estos tratamientos. Por último, la tercera pata del tratamiento que tenemos en el momento actual en el armamentario de estos pacientes son los inhibidores de los bloqueantes de los puntos de control. Hay dos tipos de grandes familias que utilizamos ahora, los anti-CTLA4, que lo que hacen es quitar el freno que se produce cuando se une el antígeno al receptor en los ganglios linfáticos cuando la célula dendrítica presenta los antígenos a la célula T. Esta señal coexpresada inhibitoria se anula con estos anticuerpos que actúan bloqueando CTLA4, y entonces ello consigue que esta señal, que es inhibitoria, al quitar la inhibición de la inhibición, conseguimos que se produzca la activación. Es decir, nosotros con estos anticuerpos bloqueamos el freno y conseguimos que se active el sistema inmunológico. Y el otro tipo de fármacos que actúan más o menos de la misma manera en otra diana son los anti-PD1 y anti-PDL1, que lo que hacen es, a nivel del microambiente tumoral, desbloquear el freno que se produce cuando se produce el reconocimiento antígeno-receptor con los antígenos expresados en la membrana de la célula tumoral. De manera que si bloqueamos esta unión PD1-PDL1 con anticuerpos contra una u otra molécula, al producirse la unión antígeno-receptor, la célula T, en lugar de emitir una respuesta de tolerancia o de anergia, se produce una respuesta de activación. Como son fármacos que lo que hacen es bloquear la respuesta de tolerancia, pueden exacerbar enfermedades autoinmunes previas o pueden desencadenar fenómenos inmunomediados. Y esto es importante porque hay que tenerlo en cuenta a la hora de seleccionar el perfil de pacientes. Probablemente en un paciente con esclerosis múltiple y cáncer hepático no debamos administrar un fármaco de este tipo, pero quizás si el paciente tiene una enfermedad autoinmune tipo una tiroiditis en tratamiento sustitutivo o una diabetes tipo 1 que ya está en tratamiento con insulina, esto no sea una contraindicación absoluta para recibir este tipo de fármacos. Además, como estos efectos adversos pueden ser muy sutiles al principio y pueden ser potencialmente graves, y quizás se nos escapa de nuestro conocimiento cómo manejar una miocarditis inmunomediada o una uveitis inmunomediada, es necesario que tengamos en nuestro centro especialistas de referencia a los que recurrir de manera precoz, y si hay que trabajar de manera multidisciplinar en el cáncer de hígado, pues en el seno de los tratamientos que pueden producir efectos adversos inmunomediados, este trabajo multidisciplinar cobra, si cabe, más importancia. En los pacientes con cáncer de hígado que recidiva después del trasplante hepático, es importante señalar que los fármacos inhibidores de los puntos de control inmunitario no deben utilizarse, especialmente están contraindicados los anti-PD1 o anti-PDL1, porque estos fármacos pueden producir con mucha frecuencia rechazo del injerto de manera grave, con pérdida del injerto y con fallecimiento del paciente. Tenemos evidencia de que en los pacientes que necesitan tratamiento sistémico en la esfera del post-trasplante, hay muy buenos resultados con monoterapia secuencial con inhibidores multiquinasa, por ejemplo, sorafenib seguido de regorafenib, y también hay series con sorafenib seguido de lenvatinib o con lenvatinib seguido de sorafenib. De manera que este es el panorama actual del tratamiento sistémico del cáncer hepático. Tenemos evidencia con ensayos clínicos fase 3, con la combinación de durvalumab más tremelimumab, dos fármacos de inmunoterapia, un anti-PD1 y un anti-CTLA4, con el estándar de tratamiento en el momento actual, anti-PDL1 atezolizumab más bevacizumab, antiangiogénico puro, monoterapia con durvalumab, sorafenib o lenvatinib. Y tenemos ensayos clínicos fase 3 en segunda línea que han demostrado beneficio en la supervivencia con regorafenib, cabozantinib y ramucirumab, y en Estados Unidos la FDA ha aprobado el uso con evidencia con ensayos clínicos fase 2 con monoterapia con nivolumab o pembrolizumab y con la combinación de nivolumab más ipilimumab, una vez más anti-PD1 más anti-CTLA4. ¿Qué ocurre? Que todos los fármacos de segunda línea se han probado, se han testado después de una primera línea con sorafenib, de manera que no tenemos evidencia para hacer secuencia de tratamiento si utilizamos en primera línea combinaciones de fármacos, monoterapia con durva o monoterapia con lenva. Y esto será un problema a la hora de diseñar la estrategia terapéutica. ¿Cómo vamos a hacer la selección del tratamiento? Pues tenemos que fijarnos en los criterios de inclusión y exclusión de los ensayos clínicos, en el perfil de seguridad y la calidad de vida asociada al tratamiento, cómo es el fármaco, si es oral o intravenoso, si el paciente vive lejos del hospital, si puede venir cada 2 semanas, cada 3 o cada 4 a recibir el tratamiento intravenoso y, por supuesto, los problemas de acceso y de reembolso. En mi opinión, hay una serie de aspectos a la hora de analizar los resultados de los diversos trabajos que están publicados. Uno de ellos es que nos tenemos que fijar en que la población seleccionada no siempre es homogénea. Hay estudios en los que se excluye de manera explícita a pacientes que tienen alta carga tumoral, o que la proporción de pacientes con cirrosis, que es el factor de mortalidad competitivo, es diferente, o si son ensayos de segunda línea, si los pacientes de primera línea están estratificados en todos los brazos de tratamiento según el patrón de progresión radiológica que han tenido en primera línea, porque la supervivencia postprogresión ya en historia natural es diferente. Si nos fijamos en los efectos adversos, cómo son, cómo son, qué intensos son, cuánto duran los pacientes en tratamiento, qué porcentaje de pacientes abandona el tratamiento por toxicidad antes de que se produzca la progresión radiológica. Si hablamos de respuesta radiológica, ¿cómo está medida? ¿Con qué sistema se ha medido? ¿Qué mide? ¿Respuesta objetiva? ¿Ausencia de progresión? ¿Cuánto dura esta respuesta? ¿Qué tratamientos secuenciales han recibido los pacientes? Porque si analizamos el fármaco A frente al fármaco B en segunda línea, a lo mejor en realidad estamos analizando la supervivencia de A más C frente a B. ¿Y cómo es el diseño del estudio? Y a modo de ejemplo, aquí tenéis dos curvas de supervivencia de fármacos en primera línea. El primer ensayo, nivolumab, para demostrar su unidad de nivolumab. Como la supervivencia no fue estadísticamente diferente, como la diferencia en supervivencia no fue estadísticamente significativa, el resultado del ensayo fue negativo y el nivolumab no ha sido aprobado en primera línea de tratamiento sistémico. Sin embargo, el ensayo del lenvatinib frente a sorafenib se diseñó en modo no inferioridad y este resultado sí que ha sido estadísticamente significativo porque el hazard ratio no llegaba a 1,08 y por eso tenemos lenvatinib como tratamiento aceptado en primera línea. Por desgracia, no disponemos de biomarcadores que nos ayuden a predecir la respuesta al tratamiento, aunque sí que tenemos eventos evolutivos con cierto valor pronóstico. Por ejemplo, sabemos que los pacientes con sorafenib que presentan diarrea en los primeros 60 días tienen una supervivencia peor. cambio, la toxicidad cutánea en los primeros 60 días se ha asociado con mejor supervivencia en los pacientes que reciben sorafenib, regorafenib o cabozantinib. Nos ponemos siempre muy contentos cuando los pacientes parten de alfa-fetoproteína milenaria y esta desciende con el tratamiento. Y esto se ha demostrado que se asocia de manera independiente a la supervivencia tanto con la combinación de atezolizumab como con sorafenib, regorafenib, cabozantinib y ramucirumab. Y aunque con los inhibidores multiquinasa una mayor respuesta radiológica no va encaminada directamente, no va ligado directamente con una mayor supervivencia, esto no es así en los pacientes que reciben inmunoterapia. Sabemos que hay entre un 20 y un 30% de pacientes que responden de manera excelente a la inmunoterapia y que estos pacientes que hacen respuesta completa o respuesta parcial tienen una supervivencia muy larga asociado de manera directa a la duración de esta respuesta. Pero como digo, antes de empezar, no sabemos quiénes son estos pacientes, no sabemos qué pacientes son los que van a responder así. En nuestro momento actual, desde el 1 de mayo de 2022, en España podemos prescribir por fin la combinación de atezolizumab más bevacizumab, que ha de ser nuestra primera línea de tratamiento sistémico y que modifica un poco el funcionamiento de las unidades de hepatología porque son fármacos que se tienen que administrar intravenosos cada 3 semanas. Tenemos que empezar a utilizar el hospital de día. Los requerimientos para utilizar esta combinación, como digo, hemos de evitarlo en pacientes trasplantados y en pacientes con enfermedades autoinmunes graves. Tenemos que tener adecuado control de la hipertensión portal. Se desaconseja utilizar en pacientes con varices de alto riesgo de sangrado y con un adecuado perfil de función renal y de plaquetas. Sin embargo, ya hay experiencia en vida real utilizando atezolizumab en pacientes Child B. Este es un estudio multicéntrico que incluye varios centros europeos, más de 200 pacientes. Hay otro estudio similar publicado recientemente en Seúl y como vemos, los pacientes Child B, pese a que la tasa de respuesta es similar, el uso de esteroides para los efectos adversos inmunomediados es similar, la proporción de complicaciones no es diferente, sin embargo, estos pacientes viven significativamente menos y yo creo que de momento tenemos que ser muy cuidadosos y muy estrictos con el uso de esta combinación, ciñéndonos a los criterios de inclusión de los estudios, del estudio en Brave. Aproximadamente un 30% de los pacientes son candidatos a segunda línea, que son pacientes con enfermedad compensada, con los efectos adversos de la primera línea bajo control, asintomáticos o con mínimos síntomas, y con los inhibidores tirosinquinasa lo que hacíamos es que en el momento en que los pacientes desarrollaban progresión a costa de nuevas lesiones extrahepáticas, era el momento que seleccionábamos para cambiar a segunda línea, porque sabemos que el otro tipo de progresiones no tenían tanto impacto en la supervivencia postprogresión. ¿Qué ocurre? Que con atezolizumab el deterioro de la calidad de vida de los pacientes a lo largo del tiempo es mucho menor que con sorafenib y probablemente tengamos más pacientes que puedan ser candidatos a una secuencia de tratamiento. Y esto es importante porque aumenta mucho la supervivencia de los pacientes que son capaces de adquirir la secuencia, de llegar a una segunda línea. De manera que en historia natural la mediana de supervivencia son 8 o 10 meses, con la secuencia llegamos a más de 2 años. Como no hay segunda línea ensayada, o sea, con estudios clínicos después de atezolizumab, se publicó este estudio analizando qué monoterapia con tirosinquinasa podíamos utilizar después de atezolizumab y con este modelo de Markov los autores indican que los mejores fármacos para hacer la secuencia, y entre paréntesis yo añado, y son los que tenemos aprobados en España, serían o lenvatinib o sorafenib, que son los que consiguen mayor supervivencia a 2 años, con menor proporción de efectos adversos y con mayor número de años de vida ganados. ¿Cuál es el futuro? Y ya estoy terminando. El uso de terapias en combinación. Tenemos resultados positivos con durvalumab, resultados positivos con atezolizumab y estamos esperando los resultados de los otros ensayos clínicos en fase 3 en primera línea. Y tenemos experiencias locales, que por motivos de tiempo no comentaré, con estudios fase 2 en segunda línea, combinando inhibidores tirosinquinasa con inmunoterapia. Asimismo, hay una gran revolución en investigación utilizando tratamiento sistémico para mejorar los resultados de los tratamientos intraarteriales y tanto en neoadyuvancia como en adyuvancia antes y después de la termoablación y de la resección. Como conclusiones, el tratamiento sistémico ha cambiado radicalmente el pronóstico de nuestros pacientes. Es importante analizar la comorbilidad, la reserva funcional y las preferencias del paciente, manejar adecuadamente los efectos adversos, equipo multidisciplinar y la primera línea de tratamiento en el momento actual ha de ser la combinación de atezo-beva. Y esto es todo. Este es mis compañeros de Asturias con los que trabajo actualmente. Muchas gracias.
¿Preguntas? Bueno, yo quería preguntar, los pacientes en los que hay progresión en el estadio B con carga tumoral alta y hay progresión con la TACE, ¿cuál sería el tratamiento sistémico más adecuado para intentar reevaluar y volver a tratar con termoablación?
De los tratamientos que, a ver, de los fármacos con tirosin quinasa hay una mayor tasa de respuesta radiológica precoz con lenvatinib que con sorafenib, que son un poco los dos fármacos de primera línea que tenemos en España. Y con atezo-beva, algunos pacientes consiguen respuestas radiológicas muy buenas, también de manera muy precoz. Lo que pasa es que a priori no sabemos cuál va a funcionar. Entonces yo lo que recomendaría es que si el paciente es candidato a recibir tratamiento sistémico, evaluaría primero si puede recibir atezo-beva y probaría con el mejor, que en este momento es atezo-beva. Si conseguimos que el paciente haga una respuesta radiológica notable y lo podemos rescatar incluso con resección quirúrgica o tras unos meses de observación, incluso si nuestro centro admite el downstaging, incluir en lista de espera de trasplante, pues fantástico. Pero sería muy realista con el paciente indicándole que lo más probable es que consigamos frenar o detener un poco la velocidad de crecimiento del tumor, y realmente son pocos los pacientes en los que conseguimos downstaging y regresión de la enfermedad de manera tan significativa como para poder volver a un estadio previo.
Sí, enhorabuena María y muchas gracias por la presentación. Mi pregunta es en relación con, efectivamente, como has comentado, combinación atezo-beva parece ahora bueno, la más razonable de primera línea, pero si un paciente, por ejemplo, ya está en tratamiento, mientras llega la aprobación y la disponibilidad amplia de esta combinación, está en tratamiento con sorafenib o lenvatinib y no experimenta, o sea, la enfermedad progresa después de un corto periodo de tratamiento y dado que no hay alternativa de segunda línea en el momento actual, ¿sería razonable cambiar? Sabemos que no hay evidencia científica que lo haga, pero ¿cuál sería tu opinión? ¿Sería razonable cambiar a atezo-beva?
No sabemos cómo va a responder el paciente porque la evidencia la tenemos en pacientes que no han recibido inhibidores tirosinquinasa previos. Entonces, yo intentaría derivar al paciente a un centro que tuviera ensayos clínicos de segunda línea de tratamiento combinado.
¿Alguna otra pregunta?
Gracias. Hola María, enhorabuena por tu charla. Una pregunta, y en relación a los pacientes con tumores mixtos, colangio, hepato, ¿alguna de esas terapias se puede usar ahora mismo en primera línea o en segunda línea o todavía estamos evaluando qué terapias poder usar?
Las indicaciones de las guías y de los expertos es que cuando tengamos un tumor mixto, dependiendo de la proporción de tumor que sea más hepato, tratarlo como si fuera un hepato; si es más colangio, tratarlo como si fuera un colangio. No conozco estudios en los que utilicen el tratamiento de ambos tumores a la vez. sea que si yo tengo un hepatocolangio que predominantemente tiene rasgos de hepatocarcinoma, evaluaría al paciente para TEZ o beva, si esa es tu pregunta.
¿Alguna pregunta más? Pues muchísimas gracias y pasamos a la siguiente charla.
Pasamos a la siguiente charla de la mesa. We are pleased to present next speaker, Dr. Víctor Navarro of Einstein University and Medical Center in Philadelphia. He belongs to the dealing and is responsible of the Healy area. He is one of the current leaders of palliative care in hepatology. The talk is entitled Principle of Palliative Care and Symptoms Management in Cirrhosis. Thank you.
Ok, buenas tardes. Buenas tardes, amigos y colegas. Me gustaría agradecer a los organizadores para invitarme a hablar en este maravilloso evento. Desafortunadamente, mis responsabilidades como jefe de Departamento de Medicina y el efecto continuo de COVID y influenza también en mi facultad no me permitirán suficiente tiempo para preparar mi presentación en español adecuado. Por lo tanto, cuando me dieron la opción de presentar mi tema en inglés, tomé esa opción. Te prometo que la próxima vez que nos veamos, te lo presentará en español aceptable. Además, no quiero que el profesor Björnsen sea el único presentador de habla inglesa. Entonces, my title, thank you for the introduction, is Principles of Palliative Care and Symptom Management in Cirrhosis. Thank you very much for your attention. My name is Victor Navarro, as was introduced. I'm the Paul J. Johnson Chair for the Department of Medicine at the Einstein Healthcare Network and Thomas Jefferson University, and I'm a professor at the medical school here, Sidney Kimmel Medical College. I have no commercial conflicts. I'm funded by an organization called the Patient-Centered Outcomes Research Institute to conduct palliative care research in patients with advanced liver disease. The Patient-Centered Outcomes Research Institute is a non-governmental organization, although funded by the US government somewhat, to conduct all types of research, especially patient-centered research. I'd like to talk about 4 major topics today. What is palliative care? Why is palliative care important in the treatment of patients with advanced disease? I want to go over the symptom management in cirrhosis and specifically reference the societies here in the United States as they have reviewed and written about palliative care, and also talk about future directions about palliative care management in the United States. First of all, the World Health Organization has defined palliative care as an approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illness. It's appropriate at any point in serious illness, and it's provided at the same time as life-prolonging treatment. Now, there are 4 major domains or areas of palliative care. The physical domain, which focuses on a patient's functional ability, their strength, fatigue, whether they're getting adequate sleep and rest, and other symptoms, as you see. The psychological domain, which focuses greatly upon anxiety, depression, distress. The social and cultural domain, which oftentimes we don't give enough attention to, specifically the financial burden of being ill, particularly in the United States, where everybody really must be insured in order to get care. Caregiver burden, that is the burden placed upon our loved ones, and even their appearance. Patients, of course, when they have advanced liver disease, their appearance can change dramatically. And finally, that's domain which we often feel great discomfort in addressing with patients. That's the spiritual domain. What their views are on hope and suffering and religion and transcendence and preparing for actual passing. Historically, palliative care was really viewed in a very black and white way, very sort of cut and dry approach. Palliative care was really thought to be that treatment which was doing nothing more than preparing a patient for a peaceful death and entering hospice, where all we're doing is providing comfort care. And that has been viewed as quite distinct from treatments that are intended to cure. However, more recently, we really have come to view palliative care and curative care as being intertwined, as coexisting. And something that is most beneficial to the patient is introducing palliative care as we're still treating patients with the intent to cure. And it's at a point will come in many patients where cure is no longer possible, it becomes evident, and the patient enters into hospice. And palliative care now even extends into bereavement care, that is providing some support for family members after the patient passes. So the most important, I think, prevalent thinking for palliative care here in the United States, perhaps everywhere, is that palliative care should be considered as symptom management in chronic life-limiting illness, and only a small part of palliative care is actually hospice care, that is treating patients at the end of life in terminal illness. And sadly, in the United States, it's only this hospice care which is covered under most medical insurances and the government insurance, which is Medicare. That being said, palliative care has really become much more common in the United States. This is a study of US hospitals between 2000 and 2016, and we can see that organized palliative care services within hospitals have really grown significantly in that period of time. So it's evident that the importance of palliative care has been recognized. And the studies out there actually show that palliative care has done some very good things. Now, I'm only showing you the points that have been shown in the literature and the first authors, but it's become clear that palliative care leads to better symptom control, better quality of life. And these are in many different diseases. This is not specifically in liver disease. It improves depression. And what's really fascinating is, as has been shown in lung cancer, that palliative care actually leads to a prolonged survival in patients with advanced lung cancer. It also leads to an improved satisfaction with care. And in the United States, patients' measures of care, of satisfaction with care, is very important to us. It is very closely tied to our reimbursement for the care we provide. It also has been shown to lead to lower healthcare use, and in specifically with liver disease, a lower liver-related cost near the end of life. Now, that being said, in liver disease, we still have problems. And this is a study, or two studies, among gastroenterologists. And what these studies did is surveyed gastroenterologists about their perceptions of palliative care. And these are the three major findings of these two studies. Only about 30% of gastroenterologists, principally here in the US, believe that palliative care is inconsistent with liver transplantation. That's to say that, many people do not believe that somebody should be getting palliative care and also be awaiting liver transplantation. And most assume that patients don't even want to hear about palliative care, perhaps because most patients perceive palliative care as being end-of-life hospice care. And over 80% of respondents in these studies believe that palliative care and symptom management are best provided by hepatologists. That being said, most would defer the consultation out to specific palliative care providers that are not hepatologists. This tells us that although there is the perception that palliative care is important, the time involved in giving palliative care means that that's time taken away from other things that the physician would be doing for that patient or for other patients. So we have a long way to go before gastroenterologists perceive that palliative care is truly part of the treatment of patients with end-stage liver disease. So then we ask ourselves, why is palliative care important specifically in the treatment of patients with advanced liver disease? Just see if I can figure how to remove this bar. Oh, there we go. Okay, there we are. So let's talk about the literature which shows how palliative care is important in patients with advanced liver disease. Well, first, to provide the context. We know that patients with compensated cirrhosis have quite good survival, median survival of 12 years, excellent 1 and 2 year survival if they're compensated. Let's say that they have no clinically significant portal hypertension, or they may have portal hypertension with no events consistent with clinically significant portal hypertension. On the other hand, patients who have decompensated disease, that is after the development of complications, whether it be ascites or variceal bleeding or encephalopathy, and these complications develop at an incident rate of about 25% per year, the 1 year survival falls as a broad statement to 60% and 45% in 2 year survival. So the point here is it's clear that patients with advanced liver disease have a poor survival. So what, aside from survival and those treatments that we're all good at providing and you're discussing today in great detail, aside from providing those treatments which are intended to stabilize or even cure disease, what's really important to the patient? And these are the questions that are asked by our funding agency, the Patient-Centered Outcomes Research Institute. What outcomes are important to the patients with liver disease? Well, we feel, after surveying the literature and talking to patients and talking to physicians, those things which are most important to patients, in addition, of course, to being cured of their disease, are symptoms, quality of life, management of depression and distress, also improvement and alleviation of caregiver burden, as well as the cost of care, because many patients find themselves in significant debt being treated for their liver disease. Now, this is a slide that I adapted from a very good study, the Systematic Review and Meta-Analysis, which looked at many symptoms associated with end-stage liver disease. And the authors specifically were looking at symptom prevalence and quality of life. And I didn't capture even all that they reported, but I focused on those major aspects that patients experience: pain, insomnia, fatigue, depression, anxiety. And what you see here is the comparison of end-stage liver disease in the dark green bars to patients with cancer in the light green bars, to the patients with heart failure in the brown green bars, and then in the orange bars, patients with end-stage renal disease. And the point to be made here, is that patients with liver disease have symptoms and quality of life impairment that essentially is no different than patients who have cancer, congestive heart failure, and end-stage renal disease. In an additional study, which looked at the economic burden of chronic liver disease in the United States, in this cross-sectional study, using a medical expenditure panel survey, a publicly available product, it was found that patients who have chronic liver disease bear significant economic burden, less likely to be employed, much higher healthcare expenses, a bigger problem with distress and depression, as well as reduced quality of life. And finally, there was this valuable study here, although somewhat old now, more than 10 years, looking at the multidimensional burden of cirrhosis and hepatic encephalopathy on patients and caregivers. The important thing that Dr. Bejaj and his colleagues did here was include the caregivers, an area of research that we have much to learn about. That is the impact of liver disease on the family and the support people who care for the patient. What the authors here identified is that cirrhosis causes significant financial, economic, and emotional burden, not only on the patients, but also on the caregivers. So what are the main messages from these outcome studies? Well, first of all, advanced liver disease complications portend reduced survival. We know that from the existing literature. We also have learned from the more recent literature that patients bear a significant symptom burden, really no different than patients who have other severe life-limiting illnesses. We also learned that liver disease causes financial and economic as well as emotional burden, not only on patients, but also on their caregivers, their family members, their loved ones, and overall quality of life is negatively impacted by liver disease. Now, I'd like to highlight the two guidelines, at least parts of them, that have been published, one by the American Association for the Study of Liver Disease on with a practice guidance, not a guideline, on palliative care and symptom-based management in decompensated cirrhosis. Dr. Verma is one of my colleagues here at our institution. And the point here is to use this as a framework to discuss ways to manage the symptoms of liver disease. This is publicly available, well written. I urge you all to read it. And the guideline authors separated out the symptoms into these 12 areas. And I'm going to touch on them very briefly because I think it's of great value. We find in our own studies that even now, in today's day and age, that physicians, gastroenterologists don't have a very rational way, for example, of treating things as common as pain. Let's start by looking at pain. Pain can be either nociceptive, which is somatic. For example, pain from hepatomegaly, pain from a tumor that might be pushing on the liver capsule, or pain could be neuropathic, such as occurs in patients with severe alcohol-related disease, with neuropathy. And our approach for nociceptive or somatic pain is with acetaminophen. Despite the fear that some patients have, acetaminophen is recommended in this country by the FDA to be kept under 2 grams a day, is safe, and in many times effective. And we find ourselves using very liberally topical applications, lidocaine, for example, and even opioids. Now, I say this with some qualification. The opioids that we tend to use, hydromorphone or dilaudid or oxycodone, are often in the hospital setting for patients who have severe pain. Of course, we always worry about dependence and gastrointestinal side effects, even constipation. We must also be mindful that there are other opioids, and tramadol, which is used quite commonly in the United States with the perception that it's not an opioid, but it is an opioid, a synthetic opioid, that these drugs in particular are more greatly metabolized by the liver and in the case of tramadol, has more unpredictable pharmacodynamics, more unpredictable side effects. So we really should be avoiding the use of tramadol. For neuropathic pain, we treat as we do in other patients who have neuropathies, using the gabapentinoids, gabapentin, for example, or the serotonin norepinephrine reuptake inhibitors we use quite commonly, such as venlafaxine or duloxetine, and even the tricyclics such as Elavil and amitriptyline. Of course, we have to be mindful of the side effects with gabapentinoids, as well as the SNRIs and the tricyclics, ataxia, discontinuation syndrome, and even a problem that many of our patients already face, sexual dysfunction. Abdominal distension is one which we deal with every day, right? This is the patient who has very severe ascites. We treat them with salt restriction, diuretics, large volume taps, and even TIPS procedures. We know this can help many of our patients, but of course, we must always put a TIPS in with in the context of whether a transplant can be done and be done safely. And in patients who are actually placed on palliative care without the intention of doing a transplant, we're very liberal in inserting drainage catheters for at-home drainage. This allows patients to remain at home, to be comfortable, and many doctors will even put patients on prophylactic antibiotics to avoid infection, me being one of them. This really should be part of end-of-life care because of the risk of infection. Dyspnea, shortness of breath, very commonly experienced among patients with cirrhosis, usually because of volume overload with ascites, effusion, and a sarca that we treat with diuresis and TAPS. But we mustn't avoid the possibility that there is one of the complications, the pulmonary complications of cirrhosis, including hepatopulmonary syndrome or pulmonary hypertension. And we consider the possibility of oxygen therapy and transplantation. In patients who have portopulmonary syndrome, which we see quite often in the United States here, we have a inpatient liver unit here of 16 beds, and we have now a record 4 patients with portopulmonary hypertension. We're in the practice now of putting patients on the transplant list with portopulmonary hypertension if their disease is treatable and they respond to phosphodiesterase inhibitors with an appropriate reduction in their pulmonary hypertension, the PVR, the pulmonary vascular resistance, excuse me. Encephalopathy, again, such a common symptom that we all treat and test for. Standard therapy is well known to us, and we have adjunctive therapies. And sometimes we overlook the possibility of using neomycin because of the renal side effects. But in this country, rifaximin is extraordinarily expensive if patients don't have insurance coverage. This can be on the order of $800 a month, where neomycin in comparison is pennies. Our residents enjoy the use of metronidazole and zinc, but unfortunately, they forget sometimes that these drugs have significant and sometimes irreversible side effects. Even here, I have a patient in the hospital who's developed a rash because of zinc. And also becoming increasingly used are the branched chain amino acids, probiotics, and even carnitine for the management of hepatic encephalopathy. Now, we always encounter patients with muscle cramps, and I'm sorry for the day when that came when we could no longer prescribe quinine because it was so effective in managing cramps for patients. But unfortunately, because of the cardiac side effects, we can no longer give quinine. So we correct electrolyte abnormalities, zinc deficiency, and we may try other things such as the branched chain amino acids, vitamin E, taurine, and muscle relaxants. I fear using these muscle relaxants because of the side effects, but sometimes patients are simply tortured by the muscle cramps. And I find that it's mostly because of the diuresis. And sleep disturbances. This is an awful side effect that so many patients with cirrhosis experience. We're all familiar with the disturbed sleep-wake cycles. Why? We know in cirrhosis there's impaired melatonin metabolism. Encephalopathy can trigger this, as well as impaired thermoregulation. And I have many patients who experience akathisia, that feeling of restless leg where they simply cannot become comfortable, and pruritus may also keep them up. And this is really a very troubling side effect. At some point, we have to empathize with the patient and tell them this must really be a bad symptom. I understand that. And sometimes we have to work with you to improve their sleep hygiene for sleep-wake timing when they eat, and also employ cognitive behavioral treatments with mindfulness and even light therapy to increase wakefulness during the day. Oftentimes, we will treat patients with melatonin, zolpidem, hydroxyzine. Frankly, I find most useful trazodone at 50 milligrams at night as a good agent to help patients sleep. Fatigue, patients are tortured by fatigue as well. This can be central because of encephalopathy, can be peripheral because of the profound muscle wasting that patients experience. And of course, we have to be cautious to look for all the causes of fatigue in our patients, and not to overlook things that could be as subtle as adrenal insufficiency, and that occurs in some 40% of patients who have advanced liver disease. In peripheral muscle wasting, we have very little to do except nutritional therapy and behavioral therapy, where we treat, we try to ameliorate, we teach the patients to cope with the fatigue, usually by sleeping when they're tired and getting them out of work, and empathize with what they're going through. Pruritus, perhaps more prevalent in certain diseases, not everyone. But there are topical therapies which I find to be entirely ineffective, but the guidelines do talk about these various local treatments. What I end up doing, and I bet you do as well, is use bile salt sequestrants, rifampin. Rarely do I use naltrexone, but I frequently use the SSRIs, particularly sertraline, I find to be effective in patients where bile salt sequestrants and rifampin are ineffective. Stress and anxiety. You know, this is something which, as physicians in most countries, I would gather, we spend the least time on in managing. And now we have various tools in order to measure stress and anxiety. I gather most of us don't use them, but there can be many causes for the stress and anxiety, from hepatic encephalopathy to nutritional disorders and sleep disorders. We use drugs quite liberally, specifically the serotonin receptor uptake inhibitors. I specifically use the Seroquel, the Zoloft, for example, I find to be quite effective. And there are also non-drug approaches, cognitive behavioral therapies, which frankly, most hepatologists are not skilled nor have the time to engage in. And sexual dysfunction is one which I think just about every patient experiences. And we have to evaluate all patients for the various causes of sexual dysfunction and realize that in cirrhosis, it's usually the result of hypogonadism, low testosterone, and poor vascular flow. Now, we do attempt drug therapy, the phosphodiesterase inhibitors, realizing that many patients find the side effects quite intolerable because of their low blood pressure and the propensity for syncope or headaches. And nausea. I find nausea to not be that common in our cirrhotic patients, but there are many causes when they occur, as you see here, and we have various treatments. The one thing to be mindful of that our residents always have to be reminded of is that ondansetron, Zofran, we must be careful in their cirrhotic population because of the potential for QT prolongation. And in patients with cirrhosis who might have advanced disease, there is the risk that they have conduction system abnormalities. So we've got to be very mindful about the possibility of causing more QT prolongation. Now, I'm not sure of the environment on cannabinoids in Spain. In the United States, it's quite variable state to state, but it's becoming much more available. We know that cannabinoids have been studied in liver disease excuse me, for a very long time. We know that activation of the CB1 receptor enhances fibrosis, and antagonism has actually shown not only to increase arterial pressure and vascular resistance, but also decrease mesenteric blood flow and portal pressure. It's not yet a therapeutic agent, of course. And in CB2, which activation can counteract progression to fibrosis, deletion actually causes an increase in collagen deposition and liver disease, suggesting that modulation of CB2 could have significant therapeutic benefit. That being said, many of our patients use it. They can be prescribed medical marijuana or now go to dispensaries and find marijuana available to them recreationally. We have to be mindful that it has certain side effects. And I left off here one of the things we're starting to see most frequently in overusers, which is vomiting syndrome, hyperemesis. And finally, isolation. I think we mustn't take for granted that patients who have liver disease and it's severe can't drive. They oftentimes can't even walk to places because they might feel too weak. And so isolation is a very, very big concern. So what do we do to counteract that? We have support groups for patients. Usually they're institutional. That is to say, every given liver center may have its own support group and also a buddy system. This is particularly useful for patients who are on the liver transplant list, who will be working with another transplant recipient to help them get support through the process. Now, I also want to highlight some things about the other clinical practice update from the American Gastroenterology Association. And this will be quite brief because I don't want to be redundant. But the AGA brings up one very important point that I think is extremely useful clinically. In fact, today on rounds, I point this out to our residents and our fellows. that prognosis should be evaluated by the providers during routine care visits and at sentinel events. What does that mean? That every time we see a patient, we really need to be reminding the patient of the mortality associated with liver disease, of the potential consequences and what they mean. And when a sentinel event occurs, as an example, a bout of SBP, we need to sit down with the patient and their family and explain how advanced their liver disease is and how deadly it can be. Also, the AGA points out that the goals of care discussion, as I just said, should be repeated at sentinel events, including during hospital admissions, before the initiation of life-supporting therapies or procedures, and on the new onset of cirrhosis-related complications. Patients, sadly, and family need to be repeatedly reminded, because when the day comes that a patient does experience a deadly or life-threatening event, these discussions will have set the stage for a much easier acceptance of a terminal event. So now I'd like to spend the last minute or two telling you about what we're doing in the United States to get us to the point of more easy integration of palliative care into practice. I'm funded by the PCORI to conduct this palliative care study. It's called PALIVER, and it is the incorporation or study of the incorporation of palliative care in the treatment of liver disease. My site is here in Philadelphia, and we have 18 sites around the country to perform this research. It is a randomized controlled trial where we take patients who are cared for in VA sites, and these are Veterans Administration sites where our war veterans or military veterans are cared for, and compare them to patients who are cared for in non-military hospitals. And we then separate each group into patients receiving palliative care by the consultants, that is, those doctors who are trained specifically in palliative care, compared with patients who are given palliative care by a hepatologist. And the hepatologists who give this palliative care have actually been trained to do so. And we're looking at a 3-month endpoint, most importantly, the quality of life. We hypothesize that because hepatologists are really the primary caregivers for our liver patients, as I'm sure you will agree, we hepatologists are probably the best ones to render palliative care and can achieve a higher quality of life for our patients. This study is about 4 years into 6 years. So in the future, what do we want to see? In the future, I think we should really strive to see the early integration of palliative care in the treatment of patients with advanced liver disease. We're going to study this and hopefully implement it. Also, we want to incorporate palliative care principles in gastroenterology and hepatology education. Gracias por su amable atención y por el privilegio de su tiempo. Thank you very much.
Any question?
Thank you, Victor. Is Raúl Andrade speaking. How are you? Thank you very much for accepting the invitation to give a speech in this meeting. I have just a comment about the palliative care and the difficulty to integrate palliative care in the pathology management of patients with liver disease because of, for example, if the patient is in a transplant list, may accept very well the concept of palliative care because he's waiting for a transplantation. But for patients who are not candidate for liver transplantation, terminology is important, you know, and palliative is associated with a dismal prognosis, so patient may refuse, and patient and caregivers, no, and relatives, no, may refuse the use of palliative medicine in this situation. So I think this is an important barrier to advance with palliative care and to implement early palliative care in hepatology. What do you think?
I agree with you entirely, Claro. Of course, and one of the points that you're making here is this term palliative care has a certain connotation here in the United States, maybe in Spain as well, that patients and physicians and even nurses think palliative care means hospice care. So in fact, one of the things we're trying to do is to change this term palliative care to supportive care, so that people won't immediately believe that you're talking about putting them in a hospice program. The other barrier we face is the time it takes. In the United States, much of how we care for patients is time-based. We are paid based upon the amount of time and, the amount of time we spend with the patient. And rendering palliative care is very time-intensive, and it's not reimbursed as well as rendering many of the clinical treatments that we give.
I'm Dr. Angeli. I really appreciate your talk. So I have one comment and one question. The comment is, I fully agree with Raul. The misinterpretation of the palliative care by patients and their family depends, I think, on the wording. Why not to call it quality care, quality of life modifying care, for example, that is quite more acceptable. It can be integrated much easier with the disease modify agents, you know. The question is, do you plan to extend the palliative care outside the hospital? Because this is the main problem, you know. The first, I think, improvement in the quality of life of patients with end-stage liver disease is to maintain patients at their home, not the hospital. So how do you plan palliative care outside the hospital?
You'll forgive me, I wasn't clear enough on the study that you see on the screen. This is all outpatient. These are patients who are not in the hospital. So the idea here is to introduce palliative care early when the patient is still at home, soon after their diagnosis. So hopefully we will answer the question that you're asking of how we will extend this outside of the hospital by studying it specifically in patients who are not hospitalized.
Another question? Okay, that's all. Thank you so much.
Thank you. Gracias.
Bien, como cada año para concluir estas jornadas tenemos un invitado especial que es el profesor Thomas Berg de la Universidad de Leipzig y también del Hospital Universitario, profesor de Hepatología y además actualmente es secretario general de la ISL, de la European Association for the Study of the Liver. Él es un experto internacional en hepatitis viral y también en otras áreas de la hepatología. Y bueno, pues creo que el tema COVID-19 e hígado pues, se adapta muy bien a pues, lo que es el perfil de un hepatólogo que ha tenido responsabilidades no solo clínicas, sino institucionales y que ha tenido que afrontar esta tremenda pandemia. Thank you very much for coming, Thomas. We are really aware that you have a very busy agenda, so we appreciate very much your willingness to be here. Thank you.
Yeah, thank you very much, Raul. It's really a pleasure, and thank you very much for the invitation, dear colleagues, to be here in Malaga and to give a summary of what we have learned about COVID-19 and the liver. And well, there are certainly some new and interesting data to share with you. So I organized my talk in the following order, really talking a bit first of this liver involvement in COVID-19, because it's still a debate how much is this infection also affecting and infecting the liver. coming about what are the risk factors when it comes to pre-existing liver disease, are the difference depending on the underlying liver disease, and then a couple of words about efficacy of vaccination strategies for treatment and prevention. Well, the liver biochemistry, this was in hospitalized patients with COVID-19, and I think this is really from the beginning really to tell you all the data we have so far are coming more or less from hospitalized patients, and also when we had the Delta and the wild type variant, and we have less data on the outpatients, the non-hospitalized patient, and not a lot of data related to the Omicron infection. But still, I think you can, it will give you a good estimate what can be expected. And in the beginning, and these were kind of meta-analyses, it was shown that perhaps an abnormal ALT, AST is present in 20, 30%, but for more prospective observational studies, it showed here, for instance, in one US center, that then in most of the patients when being hospitalized, you can see an increase in ALT and AST, but rarely very high levels. So this led to the question of liver involvement and elevated liver biochemistries, whether this is a marker of more severe disease. And as you know, it was shown in many studies that having an increased AST, but you see interestingly, and I will come again and again to this point, less so ALT is a marker of more severe disease and was associated also with increased mortality in these patients. So it's certainly a biomarker of more significant disease. One of the largest study now published quite recently in our journal, coming from the Wuhan experience, they really quite carefully looked also on the trajectories of the liver enzymes, not only mentioning ALT and AST, but also the cholestatic enzymes. And I think the observations are quite revealing. So what you can see here, those in gray or in the blue curve are those patients who passed away, who died as a consequence of being hospitalized to COVID-19, whereas the others were discharged alive. And the first thing you can see with respect to ALT, there's not a big difference. The biomarker is really AST being higher in those who died and stayed relatively stable over the time, whereas in the contrast, GGG and bilirubin was in the beginning relatively low or normal, not different from those who eventually died or survived, but increased over time. And I will show you in a minute a similar study bringing all a bit more into context. And the same holds true for the alkaline phosphatase. So if you like, in the beginning, more looking like hepatitis, AST high, and in the follow-up having more a cholestatic feature. And in this trial, they showed that also if you do all the statistics with different models, that AST and bilirubin increase stayed significant in different models as a risk factor, together with, you see here, markers of inflammation. CRP, D-dimer, you know, the thrombophilic state of patients with COVID-19, of course, the severity of pneumonia, the age, creatinine, this is troponin T. So you can calculate from this publication, according to all these parameters, the likelihood of dying of COVID-19. So the question now, if you have so many patients having elevated ALT and you see also a dynamic over the course, is there really a direct influence? Does the virus directly infect liver cells and these leading to these biochemical derangements and the poor clinical outcome? And there's really a lot of debate. And to understand these data better, you have to realize what is needed to infect cells, human cells. So you need certain receptors, and you know quite well the ACE2 receptor, that it's important for binding of the virus, but for the entry, the spike protein has to be processed, has to be cleaved by proteases. And one of the most important proteases is here the membrane serine protease 2, but also other proteases can play a role here. Then, and also the virus can also enter without these receptors just by endocytosis. But then again, furin as a protease is very much important then to process the spike protein to produce infectious viruses. And you know that still, this is still an ongoing debate whether this furin cleavage site you have in SARS-CoV-2 was introduced in a laboratory, because without this furin site, we would not have had these problems with the coronavirus too. So do we have these critical entry and processing receptors in the liver? And here you see a liver gene expression profiling of all the different cells, like hepatocytes, cholangiocytes, and other endothelial cells. And you see here the expression of albumin quite high. And you see, of course, ACE receptor and also furin, or the protein serine protease is less expressed in hepatocytes. ACE receptor mainly expressed in cholangiocytes. And you find the protease also in sinusoidal cells, and furin in most of these cells, but not with a very high abundance. And when you come to cell culture, you can see SARS-CoV can infect a various number of cells. It's not restricted to lung cells. And in comparison to the previous SARS-CoV-1, you see SARS-CoV-2 infects more efficiently the lung, perhaps less efficiently the liver, and less efficiently the gut. And this was well known during SARS-CoV-1 infection, that many patients had gastrointestinal symptoms. We see them also, the gastrointestinal system symptoms also with SARS-CoV-2, but to a lesser extent as compared to SARS-CoV-1, and also organoids, cholangiocyte, hepatocytes organoids, but also pancreas organoids can be infected by SARS-CoV-2. So this is a most recent publication in Nature Letters, giving a strong argument that SARS-CoV-2 can infect the liver and can do a lot of derangements. Coming from the Hamburg group, and they also systems biology, system medicine approach to really prove that SARS-CoV-2 has a liver tropism. First of all, they also realized in their department that most patients being hospitalized had elevated ALT and AST, again, AST more often than ALT, and that it worsens over time. A clear evidence that there's something going on in the liver during the infections. They tried to recapitulate, to prove it, to validate it with a large cohort from Michigan. Most of these patients had not so many comorbidities, were not so old, so it's really here mainly liver involvement. Again, 57% had elevated liver function test, although only a very minority had a pre-existing liver disease. And again, they saw this trajectory in the beginning, AST high, then normalized, but in some of them, and this is a bit different from what I've shown you before from the Wuhan experience, also in the end, an increase in AST, less so with ALT. And then they did a lot of these studies and showed that with immunofluorescence, they could show the ACE receptor, they could show the spike protein in cells, ACE mainly in Kupffer cells, whereas the spike protein immunofluorescence was shown in Kupffer cells and hepatocytes. They could show the expression of the proteins in the human liver here with ACE, but also with the spike protein in many cells, Kupffer immune cells and hepatocytes. And they tried to find whether, like this Koch postulate, you have to find infectious viruses from the organ. So they attracted the viruses, put it on cell cultures, and saw that they are replicating viruses and in different cell types. And then again, they showed the molecular signature with gene expression analysis. And it was interesting to see that the highest similarity in gene expression profiles were seen with HIV infection and with a more mild hepatitis C virus infection, giving a strong argument that this infection induces something that looks similar as we see in viral hepatitis infection. This was the editorial by Ellen Barnes showing how we may think about it, how liver become infected. So the virus, after ingested, if you like, enters the liver by the GI tract, and then this is the hypothesis, infect cells, and have shown you all the data giving evidence that it's directly infecting hepatocytes and thereby causing the damage with the increase in AST. If you look in autopsy studies, what you can find histological, and of course, these are the most severe cases, died because of COVID-19. I think if you see these most important features like inflammatory portal or lobular inflammatory responses, this is rarely seen. The typical picture you normally have with viral hepatitis. A hallmark is really vascular changes. You find these thromboses, endothelitis. You have here, as you can see, also congestion of the hepatic sinuses, bile plugs, and I will come later to this mitochondrial dysfunction and apoptosis, and sometimes also steatosis you will find in this liver. But I think, and this is really shown in most of them, you find vascular endothelial changes with microthrombi. And again, and this study is never cited by all these other publications because perhaps it was published in biomedicine, people are not aware of. It's really a huge study confirming what all the others found, but published some 2 years before the other papers. So they again looked at the trajectories of the different liver enzymes. And, you know, I think we as hepatologists are quite good in dealing, you know, is it more hepatitis, cholestatic-like, AST higher than ALT? This tells us something. And again, ALT, AST, no difference in those survivors or deceased. Again, AST higher in those who died but stayed stable. GGT normal in the beginning, but when the patient died, it was higher. The same with alkaline phosphatase, albumin was low, and you see here high resolution, CRP, very high in those who died. And then they correlated it to other clinical features, and they saw that the oxygen saturation was negatively correlated with AST, but not with GGT. And well, this I've shown you that the liver function in abnormalities increased. So for me, and I think you're quite aware in the clinic, if you have patients with high AST, this normally tells you it's a different pathology and can be really linked to ischemic lesions. So for me, a strong argument that here in the beginning, it's more a ischemic type, and then secondary, it's more a cholestatic pattern, perhaps not so well understood what is going on there. And this is also confirmed in a way when they looked what is correlated to elevated liver enzymes, especially AST. They thought that these trajectories of liver function appear to be highly correlated with inflammatory markers. Again, speaking more for an indirect effect on the liver by cytokines and this systemic infection. Are there any long-term consequences in these patients? Well, perhaps you have seen these patients after a severe being critical ill, being on the ICU, seeing these sclerosing cholangitis in these critical ill patients. And this is a very interesting study. So is it specific to COVID-19, or do we see it in a similar way in patients being on ICU, let's say with influenza, with the other virus infection? And this coming from Zurich, and they had a similar number compared of ICU treated patients with influenza or COVID-19, and they looked for cholestasis and for the death rate. And the first interesting observation is that cholestasis is much more often seen in patients with COVID-19, whereas those with influenza normally had no cholestasis. The contrary, when it comes to the death rate is correlated with cholestasis in COVID-19. You see starting from 7 to 56, although the numbers are low in those with severe cholestasis, whereas in influenza, most patients, nearly all, died without any cholestasis. And the risk of secondary sclerosing cholangitis was seen in those with severe, but no case in influenza. And you see here again, the peak ALT levels related to mortality outcome and related to the outcome of the secondary sclerosing cholangitis. And you see again, those patients had very high AST level. This could be indicative that there might be also an ischemic type injury of the bile ducts. Here are histological findings. You see here with the cholestasis and the destruction of the bile ducts. And this comes from Michael Trauner from Vienna, and he will present during ILC some of these data. And he looked in liver disease patients. Most of them had fatty liver disease, NAFLD, and he showed that fatty liver disease or chronic liver disease is a risk factor for this type of bile duct injury, where he found 15% of patients with underlying liver disease when they had COVID-19 developing this secondary form of cholangitis. So I would like to move forward to the question whether a pre-existing liver disease is indeed a risk factor for severe COVID-19 or death. And from the large NHS, National Health System in England, you see here the population-based study, if you like, chronic liver disease appeared to be a risk factor for more severe COVID-19, but also death. From the data of the registries, also the EASL-HEP, COVID-HEP registry, it appeared to be a bit different interpretation, linking liver disease to age on the one hand and to comorbidities on the other. And you see here, these were all patients with chronic liver disease, and the red are those who died, the blue are those who survived. And you can see here, if you have no comorbidity and you are young, you do not die, although you have liver disease. But if the numbers of comorbidities increases, and of course the age increases, then you see more deaths. So here it was more perhaps liver not an independent factor. And if you look at certain diseases, for instance, well-controlled hepatitis B under treatment, you see no difference in the survival curve. The same with autoimmune hepatitis being under stable immunosuppression, no difference. And this is confirmed here in the US. But we have the overlap perhaps with liver disease, and the most common liver disease is fatty liver disease and obesity. And I think we all are aware, if we have treated patients, that from the beginning, when we had young patients with severe disease, they were quite often obese. And obesity, you see in a clear relation, is a certain risk factor. So the question is, what makes obesity a risk factor? And it could have something to do with viral replication in the adipose tissue, because here it could be a hub for viral replication. And on the other hand, we know that patients being obese might have a pre-activated immune system. So, and under this condition of having a pre-activated immune system and then COVID leading to this cytokine storm, this may have deleterious effect on this cytokine storm. And we know that obese patients are also more at higher risk of micro or thrombi. So this may, this hypercoagulation state may in addition have a consequence on immune, on organ perfusion when you think about microthrombi. So I think it's an interesting question whether really COVID-19 and obesity, non-alcoholic fatty liver disease are two intersecting pandemics, and that we were severely hit by this pandemic because we are having these certain risk factors in our populations. And coming to the fatty liver disease data quite briefly, it was shown first here, publication from Hong Kong, that patients with NAFLD had a higher risk of disease progression, higher likelihood of abnormal liver function, and a longer viral shedding as compared to the non-fatty liver disease. You see also a difference in the D-dimers in patients with NAFLD being higher, with a higher peak concentration, in a way confirming these hypotheses that obesity, fatty liver are linked and have a more pro-thrombotic profile. And I think this is perhaps really the most interesting study. giving good evidence that perhaps really NAFLD could be also an independent factor, especially in the younger population. If you're very old, perhaps then the age, being 70, 80 years old, is so dominant that you can't see any more effect of NAFLD. But for the younger population, you see here the odds ratio can be quite high. And the reason could be that by certain changes with the disease, also the receptors and the proteases you need to process and to replicate the virus may change. We have shown, or it has been shown, that also in cirrhosis, ACE receptor is going up. And the same here with NAFLD. If you have NAFLD, you're obese with NASH, the critical entry receptors are increased. And it seems that you do not have to have NASH that this may happen. These are women for bariatric surgery, and 23 had just steatosis, no NASH. But having steatosis and NAFLD, so NAFLD without NASH, showed an increase in the subcutaneous, in the visceral adipose tissue, but also in the liver with higher expression of these entry receptors. And I like this study because it again links a kind of intersecting pandemics. What they have done here, they looked for gene expression profiles, and they looked for those genes that have been linked to COVID-19 and looked, are there other diseases having a similar expression profile? And the two other diseases with the highest similarity in the expression profiles were leukemia, you can see it here. The more yellow red, the higher the similarity in the expression profiles, and NAFLD as shown here, so that it's likely that these similarities in gene expression pattern offer a favorable environment for fatty liver disease patients for COVID-19. Well, I have half an hour, right? And we started a bit later, so I think still 10 minutes or so. A very brief word to pre-existing diseases. I think most of you are quite aware what's going on here. The highest risk factor is really cirrhosis, and especially decompensated cirrhosis. And then depending when you're hospitalized, from child A to C, up to 54% mortality in these patients. And if you're admitted to the ICU or you need invasive ventilation, then nearly all patients with a child C cirrhosis die. They do not all die from liver failure, but some of them, as shown here in an Italian study, still COVID-related mortality is a bit higher, but also other patients may develop ACLF as a consequence of this infection. And the reason why these patients are at higher risk, well, again, it could be, you heard about ACLF, that there's also an immune activation on the one hand. This could lead to a more severe disease. On the other hand, you have the immune paralysis that could also influence the situation, or that you are less responsive to the vaccine. I think there's one part perhaps missing here, and this is how patients were handled. And here we come a bit to the stigma of patients with cirrhosis, especially when it comes to patients with alcohol, or what is proposed to be alcohol-induced cirrhosis, in a situation where you have perhaps make decision because of, how many beds you have in your ICU. And what is really very nicely shown here in this study from France, where they looked on all the in-hospital mortality of patients, and you see it's really a population-based study. They thought that alcohol use, decompensated cirrhosis, primary liver care were all associated with a higher 30-day mortality, but in the same way that they have a lower likelihood of being treated on the ICU. So there can be a kind of selection process going on in who deserves the scarce beds on the ICU during a pandemic wave. Liver transplantation, well, a few words, starting first with a European very nice collaborative study showing whether liver transplant patients are at higher risk of mortality. And if you look how many patients died here, it looks quite remarkably. The overall survival not very good. If you stratify by where patients were managed at home, on the ward, ICE, you see a huge difference. But when it comes to risk factors, it appears that again, age was very much important, and whether the patient had chronic liver disease, and interestingly, being treated with tacrolimus or tacrolimus was associated even with a better outcome. So perhaps the cofactors are more important than the transplant. And this is also the message coming here from the registries, where transplant per se was not an independent risk for severity of disease. This is a Spanish cohort showing first here the incidence rates, the epidemiological. So what you see here are the number of people being infected after transplantation with a liver transplant. And here you see the overall population-based infection rate. And you see it's clearly in the same slope. If the overall general population, you have a high infection rate, then you also have a high infection rate in your transplant patient. When it comes to this incidence rate, it seems that indeed the incidence in transplanted patient was higher, according to this study, nearly twice as high as in the normal population. But the standardized mortality ratio was in fact a bit, but still significant lower as compared to the overall population. And again, they could show that the type of immunosuppression matters. If you have mycophenolate, this is a risk factor for death, especially if you have high doses of mycophenolate, and they propose that you do not have to change your immunosuppressive regimen. It might perhaps even be beneficial if you have, let's say, CNIs. But if you have mycophenolate immunosuppressive regimen, consider withdrawal, and if it's a monotherapy, switch to another approach. I think in the interest of time, I will skip this one and want to come for something that is now very heavily debated. And this is whether the vaccine, and by vaccination, especially with the mRNA vaccination, whether you can induce hepatitis, and whether this is a kind of an autoimmune hepatitis. And I think you have heard about this. And this was the first case published here in J. Hepatol. You were very brave to believe in the story. And this is not a coincidence, but perhaps really related. And you see here a patient after the, or a person after the, without any liver disease, by the way, who suffered a severe ALT increase. He was then put on prednisolone and improved quite rapidly. And they saw features also with these rosettes and the inflammation, the profile of the inflammatory response. It really resembles autoimmune hepatitis. And when you look at other cases, quite often you can find antibodies. You have typically high ALT levels, and you have more often a female predominance, but it's not only found in the mRNA vaccination, also in the Oxford, what is called Oxford AstraZeneca. Even reactivation was seen if you revaccinate in one patient, quite, I think, convincing that it's really linked to the vaccine. You see here the first, then a second dose, again an increase, and then treated with prednisone, and it resolved. The largest, let's say, data collection has now recently been published, and they collected 87 patients, again, more female. The age is relatively young, and the liver injury after vaccination was diagnosed in a median of 15 days. So it's a clear link time-wise to the vaccine. And you see here most of them with an mRNA, but also 23 with the Oxford. And they saw predominantly a hepatocellular liver injury and features of immune-mediated hepatitis. Corticosteroids were given in 53%. Resolution was seen in all but one who need a liver transplant to liver failure. And then steroid was withdrawn, and in none of the patient after tapering, after steroids were withdrawn, they saw a relapse, but perhaps we need some longer follow-up for these patients really to see whether there might be also a kind of an induction of really an autoimmune ongoing autoimmune process. And this is very interesting, and I would like to recommend to you to look at this paper because it contains really a lot of interesting information coming from the Freiburg group, Robert Timmer and Tobias Böttler. They had a patient that was primed, if you like, with the first vaccine and developed an hepatitis, but nevertheless get a second dose and then visited the center, and they did a liver biopsy, but also took blood samples, and they did the whole profile, immune profiling, and they could show that it's really a CD8 T-cell mediated hepatitis. The infiltrate in the liver was nearly purely CD8 mediated hepatitis. And this is a very interesting observation. Unfortunately, the Chinese, but also Fox News took this up. I don't know whether you have seen, it was a lot in these media because, you know, the Chinese are fighting a bit against this mRNA technology because they don't have it, and say, here, look people, how dangerous these mRNA vaccines are. And the same did Fox News. Well, is this something specific, and is it therefore really a concern of the vaccination? And you know, there is also concern of this multi-systemic inflammatory response that has been seen in children, called this MIS, hyperinflammatory syndrome. And they did a post-authorization pharmacovigilance study after the vaccine and looked for this type of multi-inflammatory response in children. And you see the huge numbers of more than 8 million that were did, and they found 12 in the children with these, and 50% of them also had, among other symptoms, a cytolytic hepatitis. So the reporting rate was 1.5 per 1 million, 2.9 per 1 million doses or children being vaccinated. But in comparison, this multi-system inflammatory response is a well-known feature of COVID per se. And if you look at these, how often these systemic inflammatory responses happen in patients being infected, it's 113 in comparison to 2.9. So clearly, again, favors, and it's important to explain this to the patient. If you are more susceptible to this type of reaction, it's more likely that you can get this by a natural infection as compared by the vaccination. Yeah, well, now you have heard about this unclear hepatitis in children, and if you see something new and the pandemic is running, you may wonder, has this something to do with COVID-19? I think so far we can't really exclude it. In some of these children, a coronavirus was found, but also this adenovirus. There's a new public health corner in the journal, so you may watch it in the EASL studio next Tuesday with a special EASL broadcasting on this topic coming from the journal on this unexplained acute hepatitis. ECDC, WHO representatives are there, and also the surgeons that transplanted some of these children. So it will be, I think, a quite interesting studio session. I would like to come to an end and just to remind you that, of course, we are now much better prepared as we were 2 years before. We have vaccines, but not only vaccines, we have antibodies for preventive, and we have antivirals. And if you are interested on the EASL position, how you handle this, I would like really to refer to this publication. Of course, we are really asking for prospective registries to really see how a liver disease affect your vaccine response. And these are the couple of slides I would like to show you, that we have now first data clearly showing that patients after transplant do respond less well to the vaccine, with only 50% positive antibody response after 2 vaccinations. These were these early days. And again, age, as always when it comes to the vaccination, EGFR, so if you have kidney dysfunction, the response is less. And again, mycophenolate play a negative role in the response. So what can you do if you have the booster? Of course, you see here's the second dose. before you start the third dose, you see already that the antibodies are going down. These are all solid organ transplant, not only liver transplant patient, but you can significantly increase it after vaccination. And the liver is more responsive than the other organs, perhaps because you need less immunosuppressive agents. And again, CNIs are not a risk factor, but mycophenolate or azathioprine is a negative predictor. So the question is, should we stop it before vaccination? And this is what some kidney transplant physicians did. They stopped 5 weeks before the next vaccination in non-responders. You see here no response. And by doing this, they were able to induce in 76% response. And these are the only data related to Omicron coming from Israel, most recent, where they looked on, again, high-risk population, and these are in the age between 60 and 100 years old. And they looked for a second booster. And the outcome here is mortality from COVID-19. So this is not related to transplant, but I think it's in a way revealing that if you do not have a response, for instance, in a transplant patient with certain risk factors, that by a booster, it's likely that you do something good and that you can reduce mortality. Well, I just want to make you aware that there's, again, perhaps, I don't know whether there will be a final position paper, and this is really also related to what you can do in treatment. And with respect to vaccination, of course, we clearly recommend vaccination. We are aware that we can't really tell you what is the optimal scheme you should do. 3 doses of vaccine or equivalent 3 exposures to spike protein means if you have 2 vaccines and then Omicron infection, this means also 3. But we think that in some situations, high-risk situation as transplant patient, perhaps a second booster would be something reasonable. And we are also addressing the point of preventive treatment. This is too complicated really to explain here in a talk, but overall we really recommend monoclonal antibodies, but also the antivirals even early in the phase, because only then you're effective. In the early stage where there's viral replication, antivirals are not any more effective if you are in the inflammatory response phase in patients with a certain risk. And we also believe that patients, with decompensated are considered immunocompromised in a similar way as the recommendations are, and we are more in favor of giving passive immunization to these patients. So with this, I want to end, and of course to invite you all in 4 weeks from now to join EASL's ILC and to see you in London. Thank you very much for your attention.
Thank you very much, Thomas. Thank you for this excellent presentation. Plenty of new data and absolutely covering everything in the field of COVID-19 and the liver. There are any question or comment? I would like just to ask you about this secondary sclerosing cholangitis, because Einar knows very well the syndrome is associated also with the use of drugs, and maybe that some of these patients that were in the intensive care unit could receive at the same time having COVID-19, severe COVID-19, receiving any drug that are being involved in this syndrome. Do you know something specifically about that?
Yeah, perhaps the numbers are still not high enough really to draw a firm conclusion, but of course this may play a role. Mm-hmm. And I think these typical, let's say, jaundice on the ICU, mm-hmm. we always claim it's multifactorial even without COVID, and of course medication can play a role, but it's so difficult really to dissect mm-hmm. what is the most important driver in this situation. So to be honest, I can't really give you a firm conclusion. There is the one, I'm just missing the type of sedation treatment that was linked. Do you know? Yeah, ketamine, sorry. There's a suspicion that ketamine you should at least avoid in patients with COVID when it comes to mechanical ventilation. Yeah.
And I have another an additional question. What is the meaning of, in your opinion, of persistence of liver test alteration in patients once they are recovered from COVID-19?
To be honest, I haven't really seen a clear, let's say, long-term consequence in terms of a chronic hepatitis or so. But several patients with really very severe secondary sclerosing cholangitis. And in my view, but again, it's anecdotal, they had really a more rapid deleterious course, as we know from other patients with ICU-related secondary sclerosing cholangitis. Many patients really died before they get the transplant. They were in very bad condition. This is, well, perhaps we really need more data collected to get a better picture here. I don't know how many patients you had in your unit and whether you had the same experience.
I have only, you know, anecdotal experience on that. And sometimes the you know, the liver tests come back to normal. No?
This is what we normally see. If they resolve, then the liver enzymes resolve. So the only long-term consequences I have seen are really these cholestatic sclerosing cholangitis, ischemic type lesions.
Aina?
Thank you for this excellent presentation. I think you showed one control study. Most of these studies have not had a control group with COVID in the ICU and in hospitalized patients in liver tests. We did a study in our country, several hundred patients hospitalized, and compared them with the swine flu. I know there was a very, to our surprise, elevation in liver was very similar in the two groups. And we were disappointed, if you can say that in the COVID-19 with all these liver tests, we had no really serious outcome in the patients.
Yeah, that's interesting and a bit, but have you seen also some with these sclerosing cholangitis? Because this is a bit the message from the Swiss group. And I also talked to Beat Müllhaupt, who is a senior author. He really felt this is really something in there, and the same impression from Michael Trauner's group, that this is a bit different from the typical, let's say, sclerosing cholangitis, or let's say the frequency is a bit different. But I fully agree. We also see it in other patients with having a very severe course. I think what interesting to get your thoughts. What I normally see also in these patients with this secondary sclerosing cholangitis, that they had typically when they come to the ICU a shock, you know, with AST levels of 5,000 and so on. And then always my feeling was, well, due to the shock, they had ischemic biliary lesions. And this is not so typical here. You know, they do not start with a shock immediately. It's more a slow progression with several organ failures, and of course, starting with the lung.
So I was a reviewer of the paper in Liver International, so I get them to be a little bit moderate, because it's very difficult to distinguish from other patients.
Yeah, absolutely.
Due
fair
to
comment and fully
critical care illness, you know, it's a lot of information from Germany.
Yeah.
Any other question? So thank you very much again, Thomas.
You're welcome.
Fantastic.
Thanks a lot.
Thank you. Bien, pues llega el momento de cerrar estas jornadas, como cada año. Nuevamente mi enorme agradecimiento a ponentes, moderadores y por supuesto a todos los que estáis aquí, ¿no? Atendiendo, y también a aquellos que lo hacen online, ¿no? Estas jornadas que realmente tratan de poner en actualidad pues muchos temas de interés en hepatología. Y dicho eso, pues yo quería además agradecer a la industria farmacéutica su apoyo para hacer posible que podamos traer también pues ponentes de distintas partes, no solo de España, sino de otros países. Y es una colaboración que es imprescindible para la calidad, mantener la calidad del curso. Por tanto, mi agradecimiento de nuevo. Y también, de forma especial, también quería agradecer a las personas que dan soporte tecnológico a que las jornadas se puedan retransmitir en streaming, ¿no? Y en directo, que son del CTI de la UMA, Álvaro Hidalgo, Mario Ferrer, Isabel Barrajón, y de Sombra Doble, Carlos Martín. Muchísimas gracias, creo que todo ha ido perfecto, no ha habido ninguna incidencia, ha sido realmente algo que casi no es ni español, porque en España suelen fallar las cosas, pero parece que ha sido de otro país. Bien, y también agradecer, por supuesto, a la logística de Viajes Challenger, que da soporte pues, a todos los que vienen de fuera y también que pues, nos atienden durante las jornadas en todas nuestras necesidades. Muchas gracias. Y por supuesto, os convoco el año que viene a las nuevas jornadas que serán, ya está decidido, siempre son en la tercera semana de mayo, y esa tercera semana tocaría el año que viene, en el año 2023, los días 18 y 19 de mayo. O sea que apuntarlo en vuestra agenda, bloquearlo para que no tengáis ni primeras comuniones, ni bodas, ni nada, o sea, prohibid los eventos familiares y sociales en esos días. Y bueno, también quería agradecer, que no está aquí ahora mismo, a Aurélie Papineau, que ha hecho una labor también de organización fantástica, dando apoyo incondicional a cualquier y resolviendo cualquier problema que ha habido durante la gestión del curso. Pues nada, muchas gracias a todos, que paséis un buen fin de semana y hasta el año que viene, en esta jornada.